things that you do.
Thank you.
It's fantastic.
Thank you, Frank.
Good evening, and welcome to the Silverthorne Pavilion for Keystone Symposia's second community forum of 2014. We really appreciate your joining us tonight for this discussion on chronic pain, migraine, and the brain. My name is Yvonne Paseiler. I'm the Director of Marketing and Communications at Keystone Symposia. And I would also like to thank my colleagues, my many colleagues, for helping to plan this event, especially Mary Jo Roll, our Director of HR, and Dr. David Woodland, our Chief Scientific Officer, who unfortunately is in Europe this week and can't be with us. We would also like to thank Dr. Roseanne Shaw, who procured our local speaker, Dr. Ross Dickstein. And my colleagues and I would like to thank the town of Silverthorne for providing us use of this lovely facility. We are holding this event in conjunction with our scientific research conference on pain at Keystone Resort that's underway this week. As some of you may know, Keystone Symposia is one of the county's largest nonprofits. We've been organizing life science and biomedical research conferences for the past 42 years. While we hold many of our conferences around all over the world, approximately a third of the nearly 60 we hold each year are actually here in Summit County at Keystone, Breckenridge, and at Copper Mountain. And the one currently underway at Keystone is actually the last of our 2013 to 14 meeting season. And two of its scientist organizers have very graciously agreed to speak on our panel tonight. Dr. Frank Parecka is the lead organizer of our scientific conference. He is professor of pharmacology and anesthesiology at the University of Arizona in Tucson and specializes in mechanisms of opioids and understanding pain-induced motivational behavior to develop better pain medications. He is one of the 10 most cited pharmacologists in the world, by the American Society for Pharmacology and Experimental Therapeutics. He received also the American Pain Society's Frederick W. Kerr Award in Basic Research in Pain for his discoveries regarding the adaptive nature of the brain following nerve injury. Dr. David Dodick, while originally from Canada, is also now based in Arizona at the Mayo Clinic in Scottsdale, where he is a professor of neurology and a consultant in neurology. He is the program director of the Mayo Clinic Neurology Residency Program and the Headache Fellowship Program, as well as medical director of its headache and concussion programs. He's also president-elect of the International Headache Society, immediate past president of the International Headache Society, and the chair of the American Migraine Foundation. And his specialty is the study of headache and migraine. And finally, our local speaker, Dr. Ross Dickstein, is an anesthesiologist who specializes in spinal pain and interventional pain management from his medical practice in Frisco, Colorado. Before moving to Summit County 15 years ago, he was an assistant professor at Johns Hopkins University in Baltimore. The three panelists are going to be giving brief presentations, and then we hope to have a lively discussion based on your many questions. Please be advised that SCTV is filming the event, and including the Q&A session at the end. So we'll start off with Dr. Dickstein, followed by Dr. Parecka, and then finishing with Dr. Dodick. Thank you very much for coming.
Good evening. I'm gratified to see so many friends and colleagues and patients. Thank you all for coming. I'd also like to thank the sponsors of the Keystone Symposia for arranging this panel discussion. Before the remarks of our two distinguished guests, I'd like to briefly acquaint you with our topic tonight. What is pain? One of the most widely accepted official definitions of pain is that it is an unpleasant sensory and emotional experience arising from actual or potential tissue damage. There are two key points in that definition I'd like to tell you about. Number one, there's an emotional component to pain, which often causes suffering in addition to the physical sensation of pain. Number two, the cause of pain is not often visible, whether to the eye or sophisticated imaging, although that may be changing in the next few years. Because we cannot often see the cause of pain, nor measure its intensity with medical instruments, our second definition is, pain is whatever the person says it is, existing whenever he or she says it does. This emphasizes the truly individual experience of pain. There are many types of pain, but of particular importance is the distinction between acute pain and chronic pain. Most of our discussion tonight will be on chronic pain, but a basic understanding of acute pain is essential. Acute pain is usually the result of injury or illness, such as a broken bone or appendicitis or putting your hand on a hot burner. Injury will activate nerves in the skin or the bones or in the abdomen. These nerves will then connect or synapse with nerves in the spinal cord and then travel on to the brain, where we ultimately perceive the pain. Acute pain serves a vital function, telling you something is wrong. Move your hand off the burner. Get help. Go see a doctor. Then, as the cause is treated, whether by fixing the broken bone or removing the diseased appendix, acute pain usually fades fairly rapidly and completely. Chronic pain is a different animal. For one thing, by definition, it lingers more than 3 months, and perhaps for a lifetime. For another, while it may follow acute pain, in many people there's no ongoing injury or illness. In distinction to acute pain, chronic pain does not usually serve a protective effect. Rather, it only contributes to suffering. The nerves causing chronic pain continue to fire spontaneously. What are some of the causes of chronic pain? Migraine headache is a frequent cause, and this will be discussed further by Dr. Dodick. Other causes are cancer, and paradoxically, the treatments used to treat cancer, such as surgery, chemotherapy, or radiation. Another cause are neurologic diseases, such as stroke, post-shingles, or multiple sclerosis. Metabolic problems like diabetes and rheumatoid arthritis are frequent causes. My own interest is that of painful spinal conditions such as spinal stenosis and herniated discs. So why do we care? Well, chronic pain has enormous costs, not only to the individual, but to society. Pain is the most common reason that people seek medical attention. It impacts not only the person's comfort, but their mood, their sleep, their spouse, their sex life, their family, and their ability to hold a job and make a living. Chronic pain is truly a family affair. Then there are the huge economic costs. In the U.S. alone, chronic pain is estimated to contribute to $300 million per year in medical expenses, and another $300 million per year in lost productivity. Fortunately, through the efforts of doctors like Dr. Dodick and Dr. Parekha, we're getting better at finding the causes of chronic pain. Treatment is also improving. We're using existing drugs more effectively and developing new drugs to treat pain. Dr. Parekha will address this, and with that, I'd like to turn over the microphone to him. Thank you.
Okay, thank you, Ross, and good evening, everybody. Thanks very much for coming out. I'm really delighted to have the opportunity to tell you a little bit about chronic pain. I'm going to be focusing my remarks on chronic pain, and Dr. Dodick is going to be addressing the issue of migraine. And although these are separate conditions, they are related, and I think that both Dr. Dodick and I will be giving you the same message, and that is that these are both conditions that affect the brain. And so that's where we have to seek to understand how the conditions occur, and that's where we have to work to try and find new medicines for treatment that can help patients. So I'm going to be giving you just a couple of little messages in this very short presentation today. The first thing that I'd like you to understand is the scope of chronic pain, how it impacts our society, and how it impacts individuals and their relationships with families, as Dr. Dickstein's already pointed out. The second thing that I'd like to do is to, again, emphasize the distinction between the kind of pain that we experience in our daily lives and what chronic pain is. And then I'd like to understand the idea that we don't really have good therapies for the treatment of chronic pain, and that we really need new medications that can help patients. And one of those medications that we use right now for the treatment of chronic pain is a little bit controversial, and these are the opioid drugs. And you probably are familiar with the idea that opioids have impacts both on society and, of course, are essential for the needs of individuals. And so that's a controversy that is ongoing and that I think we have to talk about. And so I'll end with that. So let me just begin by giving you a little sense of the scope of pain in the United States. Dr. Dickstein already touched on this, but I'm going to rely on some data that were presented by a report from the Institutes of Medicine of the National Academy of Sciences. And this was a congressionally mandated committee that was charged with trying to understand the scope of pain or the impact of pain in the United States. And what the report reveals that there's 116 million people that are impacted by pain annually. So if you think about our population as about 320 million people or so, that's about a third of our population. Now, of these 116 million people, about a third are impacted by chronic pain. And so I'll tell you about this distinction between acute and chronic pain a little bit more in a minute, but that's about 10% of our population. So that is an enormous number of individuals that are suffering. The economic costs of pain in the United States estimated at this figure, $560 to $635 billion a year. And that's both in terms of treatment costs and in terms of loss of productivity. And so that's an enormous number. And what was most important in this report was were the following points. And that is the first, that this is estimated to really be an underestimate of the true scope of pain in the United States. And secondly, that the Institutes of Medicine projects that these numbers will only grow with the aging of the population and with the impact of age-related disorders such as osteoarthritis and lifestyle-related issues such as obesity and the development of diabetes. So the impact of these estimates to the citizens of the United States, and you may take note of this, estimated at $2,000 per person per year. So that's quite remarkable. So this is what the committee concluded. They said that pain in America represents a public health crisis, that its treatment is a moral imperative, and that's something that I want to emphasize, and I want to come back to that point in just a couple of moments. And finally, that pain is a medical concern that needs a cultural transformation in the way that it is viewed, in the way that it's assessed, and in the way that it's treated. And so that's what we are trying to do, is to understand and educate and expand our ability to deal with this enormous impact. So let me talk for a couple of moments about the kind of pain that we experience in our everyday lives. So as Dr. Dickstein pointed out, pain is something that is the result usually of an injury. It occurs when there's some stimulus, some damage that is maybe harming our bodies. And so we need to know about those kinds of situations, and we need to take actions to avoid those. And so this is something that helps us to survive. It's something that we need. Now, the other role of pain is to help us to learn. So once we reach out and touch a hot stove, we learn very, very quickly never to intentionally do that again. So pain is very, very important in helping us to guide our decisions so that we don't take and engage in risky behavior that can produce damage to our bodies. And so if we think about this, then we understand that this is the kind of pain that we can think of as good pain. This is pain that helps us to survive. We need it. Without it, we would have an inability to live a normal life. So we need pain. Pain is actually a good thing. We don't like it, but it's a good thing. Now, the difference between that kind of pain and what we call chronic pain is really night and day. So chronic pain is sometimes defined as by a duration. So Dr. Dickstein said it's pain that can persist for 3 months or 6 months. But the way to think about it really is that it's pain that's there long after the body has been completely healed. And it's there for no apparent reason. And it persists, it doesn't help us in any way in terms of living our lives. It doesn't teach us anything. It's there because there is a change in the nervous system. It's an adaptive state of the nervous system that is not beneficial to our survival. So this is really, chronic pain is a disease, and that's how we have to think about it. We have to understand it as a disease, and we have to investigate exactly how chronic pain actually occurs by these changes in the nervous system. Now, I just want to give you a couple of perspectives on chronic pain. And this came from a survey of chronic pain patients in Europe, actually. But the important points are the following. 40% of people with chronic pain reported that they were unable to function. They were unable to concentrate. And so these were individuals that couldn't live life. They couldn't hold jobs. They couldn't participate in life. So chronic pain is debilitating. It really affects the lives of individuals. 30% reported that their loved ones did not believe the intensity of their pain. And so chronic pain affects individuals, but it affects families. It affects relationships. And so it's devastating in a different way. 16% of the people that were interviewed actually wished for death. And so if we think about that, that's a population that we couldn't help medically. So we didn't have the tools to help those individuals. So what is the role of the brain in pain? And here we're really helped by very new techniques and technologies that are rapidly evolving and are rapidly being brought into investigation. And so we have this technique called brain imaging that allows us to really peek into the brain of living humans and start to ask questions about what the brain looks like and how it actually works. And so these imaging technologies are now helping us to understand how chronic pain changes the brain and how the function of the brain is changed by chronic pain. And this is a technique that is applicable to chronic pain, but it's incredibly important for many other neurological disorders, including migraine. And so this has been recognized by our government, and I wanted to highlight the BRAIN initiative that was announced by the Obama administration. And I wanted to read you this quote from President Obama, who states that as humans, we can identify galaxies light years away, and we can study particles smaller than an atom, but we haven't unlocked the mystery of the 3 pounds of matter that sits between our ears. And that's completely true. And so it emphasizes the complexity of the brain and the complexity of the function of the brain. So what actually happens in chronic pain? Well, what happens is that the brain changes. And so whether it's the pain that changes the brain or whether the changes in the brain sustain the pain is not completely clear. But the structure of the brain changes, and we can see this with this imaging technology. And so we have alterations in structure that correlate very, very well with the duration of the pain and with the intensity of the pain. Now, the good news is that in individuals in which the pain has been resolved, this appears to be a reversible process. The function of the brain, the activity of the brain changes. And so we can see this again. And so in many different parts of the brain that is from a chronic pain patient changes in terms of how its activity patterns occur. And as you would predict, the function of the brain actually changes as well. And so patients with chronic pain sometimes have changes in their ability to make decisions and to function properly. So chronic pain changes the brain, and it changes the way that patients function. So that brings me to how we treat chronic pain. And so what I've got on this slide is a list of drugs that you can see up in the upper right corner. And it's for treatment of a particular type of chronic pain called neuropathic pain. And that's not particularly important, and the names of the drugs aren't important at all. But what is important is that all of these drugs are drugs that produce very, very severe side effects. And so what we'd like to do in treatment of pain is we'd like to be able to give medications that completely takes the pain away. And the problem is that many of these medicines produce side effects that don't allow us to do that. So patients can't tolerate these medications, and in many cases, they have to live with pain. And so you can see in the lower right that 30 to 50% of individuals with this type of chronic pain suffer from intractable pain, pain that we can't really treat. And so it could be because of the side effects, it could be because the drugs that we have are just not that good. And so the message is that we need new drugs. We urgently need to discover new medicines that are more effective and more tolerable in the patients. Now, you can't really see it, but on this slide, maybe the fourth one down or so, is a class of drug called the opioids. And the opioids are an important class of drugs for treating pain, but they're also very controversial because they really start to raise issues that are of societal concern. And they're, of course, drugs that are very important for individuals. And so these are drugs that start to make us weigh the rights and the needs of individuals with the needs of society. And I wanted to show you this quote. This came from our Attorney General. This is Eric Holder writing in the New York Times on March 10th, 2014, so just a couple of months ago. And I want to read this quote to you. Mr. Holder writes the following: when confronting the problem of substance abuse, it makes sense to focus attention on the most dangerous types of drugs. And right now, few substances are more lethal, and just think about this word here, more lethal than prescription opiates and heroin. And so this really, I think, emphasizes the confusion that exists about opioids. Opioids are used appropriately. It can be used appropriately for medical use, but they also have this property of abuse. And you see that Mr. Holder is mixing the use of prescription opioids, drugs that are medically approved by the Food and Drug Administration, and heroin, which has no medical use. Let me just go on with this quote from Mr. Holder. He writes that addiction to heroin and other opiates, including certain prescription painkillers, is impacting the lives of Americans in every state, in every region, and from every background and walk of life, and all too often with deadly results. Now, when you think about that, we can sort of see where Mr. Holder is coming from, because this is what he's looking at, this is what he's dealing with, and these are the rates of unintentional drug overdose deaths, and you can see it spiraling upwards in time. And so that's the issue, and that's the problem with society. But the problem is that we still have the medical issue. And so if we go back and ask, are opiates useful for the treatment of pain? In fact, opiates do have approved uses. And so opiates are our mainstay drugs for the treatment of acute severe pain, for trauma and for postoperative pain. They are the mainstay drugs, the cornerstone of treatment of cancer pain. They are the mainstay drugs for palliative care in terminal conditions. And what you see written in red is where we have uncertainty. So what we don't really know is whether opiates are effective over the long term for the treatment of chronic pain. And so here is where we don't have enough data. We don't have information on how useful opiates are for long periods of time, for periods of many years in individual patients. So we don't really know if the quality of life of an individual has changed with use of opiates, if it's maintained, if it's diminished. And so what we need to do is to get that data. But the problem is that the lack of data really hasn't stopped the legislators. And so in many cases, the legislators are devising policies to regulate opioid prescriptions and overprescribing, opioid misuse and diversion. And the concern here is this: you can't really legislate away chronic pain. That's the problem. And so if you legislate that only a certain amount of drug can be given, what you've done is you've taken the decision away from the physician that actually is treating that individual patient. And so the problem is that individuals are now more reluctant to prescribe opioids, and some would argue that they should be more reluctant. But again, the medical decision is between the doctor and the patient. And so I'm just making this point that in many patients, perhaps not in all, but in many patients, opiate analgesics are really likely to be indispensable. And they're very, very useful. And there are ways to assess how opiates are given so that individuals minimize the risk of abuse. So the last thing I wanted to tell you is that the reason we're having this debate about opioids is the following. So this came from a paper that was published 7 years ago, but really nothing's changed. The paper was influential because it came from authors at the Food and Drug Administration. And I'll just read you this little part of the paper where they say that virtually all new analgesics approved over the past 25 years are derivatives or reformulations of opioids or aspirin-like drugs. So just stop and think about that, and what that shows you how successful or unsuccessful we've been in developing new medications. And that's why we're having this debate about opioids. And if we had a drug, a medicine that was capable of treating chronic pain, that didn't produce these questions and concerns in society, then we wouldn't be using opioids. And the trouble is that right now we just don't have those medicines. And that's really the main message, and that is that we really need to continue to support efforts to discover new medicines that don't have these concerns. And this is really an effort that many of us in the pain community are committed to. And hopefully we'll be able to achieve that. So right now, opiates remain the gold standard for the treatment, for the control of severe pain. But really what we need are drugs that are not opioids. And so we're trying to achieve that right now. And so anyway, that's my message about chronic pain. And I guess we'll have time for questions after that. Thank you.
Evening, everybody. Pleasure to be here tonight. I want to thank the Keystone Symposia for giving us the opportunity to really assemble the world's brain trust on pain and on migraine. We're in the middle of a 4-day symposium up here at the Keystone Lodge, and it's really been a great experience for me to learn from such knowledgeable scientists and clinicians from all over the world. And I think this is just a wonderful community outreach that the Keystone Symposia has put forth here, so it's a pleasure to be part of it. I'm going to talk to you a little bit about migraine. How many of you in the room here have migraine? I see maybe 15 hands. And of those who raised their hand, how many of you have, how many of you are your lives impacted by migraine? So a good portion. So that's pretty much what I get from every audience, because migraine is a very common disorder, which we'll talk about, but one which has been stigmatized, marginalized, and ostracized. When I was a medical student, and I trained at a pretty good medical school, I got 0 hours of education in pain and 0 hours of education in migraine. I'm not that old. And when I did my specialty training in neurology, I got 2 hours of training in migraine and other headache disorders. And lo and behold, it's the most common disorder that neurologists see when they're in practice. So we haven't been doing a very good job at equipping physicians to deal with migraine or pain in general when they're out there in practice, because that's a large part of what doctors see in clinical practice. So let me just pull up my slides here. So Dr. Parekh reviewed with you this Institute of Medicine blueprint on relieving pain in America. As he said, this is with the Patient Protection and Affordable Health Care Act. This was a congressionally mandated opportunity that the Institute of Medicine took and created this blueprint for pain in America. And he told you how many Americans suffer with acute and chronic pain. By the way, of the 116 million or over 100 million with acute and chronic pain, about 45 million of them have headache. That's the acute or chronic pain that they suffer from. So headache constitutes, as we'll get to in a moment, a large proportion of the people who suffer from acute and chronic pain. And as he mentioned, it's very costly. Another congressionally mandated occurrence happened with the Affordable Health Care Act, and that was the development of what's called the Interagency Pain Research Coordinating Committee. And that's important because based on this blueprint, as Dr. Parekh said, pain has become a public health crisis, and now it's become a national public health priority. So I'm fortunate to be involved in this national pain strategy, which has been going on for the last year. And basically, it's brought together all of the stakeholders across the United States to put together a comprehensive population health level strategy for pain, education, both physicians, healthcare providers, as well as the public, management, prevention, and research. So this has become a national public health priority, which for those of us who have chronic pain, this is a good thing. So let's talk a little bit about migraine. The World Health Organization recently completed a study over the past 10 years. They published this in 2012, and they looked between 2000 and 2010 at 291 medical illnesses across the globe and found that migraine is the third most prevalent medical disorder in the world, and it's the first or the leading cause of neurological disability in the world. So if you put all the neurological diseases that we know of, and we know of a lot of really nasty neurological diseases like Alzheimer's disease and Parkinson's disease and ALS, if you put all of those in the bucket, it doesn't come close to the neurological disability that migraine causes because of really the prevalence of the disorder and the suffering that occurs. So migraine accounts for more than 50% of the neurological disability across the world. And in women in particular who suffer 3 times as commonly as men, it's the 4th leading cause of disability in the world among women. So it's a very common and it's a very disabling medical disorder. In the United States, about 48 million Americans have some form of migraine. That's a lot of people. Up to 9 million will experience symptoms almost daily. I didn't ask those of you who raised your hand how many of you have symptoms daily, but every day I'm in the office, I see people who have continuous pain, and it may be weeks, months, years, or decades that they've had a waking moment pain-free. About 120 million lost work school days each year from migraine, and about 900,000 Americans will suffer a migraine attack today. These are some of the friends that migraine keeps. And this is why if the attacks alone and the chronicity of this disease weren't enough, these are some of the friends that migraine keeps. So these are what we call comorbid diseases. And that means that these occur more commonly in people with migraine than they do in people who don't have migraine. So everything from stroke, coronary artery disease, congenital heart defects, psychiatric disorders such as depression and bipolar disorder, chronic pain. So chronic pain is more common in patients who have migraine. Pregnancy-related stroke and other vascular complications, irritable bowel syndrome, restless leg syndrome, epilepsy, and the overuse of medication. Because for people who have frequent attacks of pain, they take a lot of medicine. Desperate people do desperate things, and patients with chronic pain are desperate. And these medications can lead to systemic toxicity on the kidney, on the livers, on the gut. So migraine is a serious disorder in and of itself, but it also comes with a lot of other serious disorders as well. Now, many of you, and this was what I thought when I was a neurology resident, that migraine was a vascular headache because of the throbbing, often the throbbing or pulsatile nature of the pain. Sort of boom, boom, it beats with your heart. And for 350 years or more, we thought that migraine was simply a vascular headache because of that pulsatile nature, and also because of the drugs that we use are drugs which often constrict blood vessels. So you take a medication that constricts the blood vessel, you get relief of the pain, therefore migraine must be a blood vessel disorder. And in fact, for many years, the onset of migraine was thought to be due to spasm of the blood vessels, which sometimes causes neurological symptoms, and then the pain comes when those spasming blood vessels then distend and dilate. And when you dilate an artery, that can be painful. So for many years, that was the subtext of migraine. But now we know that migraine is an inherited neurological disorder, and as Dr. Parekh said, migraine occurs in the brain. So 90% of migraineurs will have a family history of migraine. And for those other 10% who tell me that they don't have a family history, they probably do and they just don't know it. Because back in the day, people wouldn't go into the office, or even today, people who come into the office with migraine, 50% walk out without a diagnosis. So 50 years ago, people who were coming in complaining of severe headaches were not getting a diagnosis of migraine. So for those people who don't have a family history, I usually think that probably they don't know their family very well, or someone in the family has it and they just don't know it. Migraine without aura, and I'll talk about aura here in a second, the risk of having migraine in the family is twofold. And if you have migraine with aura, and the aura is the neurological symptoms that occur with migraine, which we'll talk about, the risk is 4 times. And the concordance in twins, in other words, if you have an identical twin pair and one of the twins has migraine, then the other twin is more than 50% likely to develop migraine as well. So we've known for a long time that migraine is an inherited disorder. We've identified some genes for one particular subtype of migraine. And those genes are passed down in what we call an autosomal dominant fashion. So if someone has this particular type of migraine that causes stroke-like symptoms, the offspring will have a 50% chance of developing migraine. But most migraine is what we call complex. It's complex genetically. So likely there are multiple genes, and about 22 now have been identified, that increase the risk of having migraine. We're a long way from understanding the genetics of migraine. We're getting closer, but no question that migraine is an inherited disorder. And I took this from one of my colleagues from UCLA who presented today. Most people think of migraine as just a bad headache. In fact, migraine's sort of become a euphemism for, headache has just become a euphemism in society for everything that's a nuisance. And oftentimes these patients, that's the way they're treated, unfortunately, when they come to the attention of a healthcare provider. But migraine is so much more than a headache. Migraine is a very complex neurological event. Headache is one symptom, and headache may not even be a symptom of a migraine attack. So as you can see here, migraine is often divided up into 4 stages. The premonitory phase, which is the phase before the headache, where patients will start to notice symptoms that reliably will predict the onset of the headache. So sometimes patients will report yawning, or they'll urinate more, or they'll complain of neck pain, or fatigue, or changes in mood, or light sensitivity or sound sensitivity, and that may begin before the attack. Some patients complain of nausea even before the pain begins. And then some people will have this aura where they'll have spots in front of their eyes, or zigzag patterns, or blind spots, or sparks in front of their visual field. Or sometimes they'll develop stroke-like symptoms where they'll have numbness in their face, down their arm, they'll go down one side of their body. Sometimes they can't express themselves. Sometimes they can't sort of comprehend speech. Some of my colleagues who are physicians who have migraine, when they go back and look at their dictations after seeing patients and they've had a migraine attack, their speech and their language is clearly unrecognizable, and they have to go back and dictate it all over again. So they have expressive language problems and also receptive language problems. They can't quite understand what people are saying to them. And cognitive problems. There's hardly a patient I see who will not tell me they have difficulty concentrating, difficulty focusing, difficulty with their short-term memory, difficulty processing information, because the brain is busy processing the pain. Then, of course, the headache, which is a very prominent feature of the attack, and then other symptoms. And importantly, now with these functional imaging, the sophisticated imaging that we now have available, each of these symptoms has an imaging signature in the brain. So we can look in the brain, and when you have nausea, we know where in the brain there's going to be activation. When you have headache, we know where in the brain there's going to be activation. So each of the symptoms that a person with migraine has, they're not making it up. It actually has a signature in the brain. So some part of the brain is not functioning properly, and that's giving rise to the symptom that they have. I added another phase to this, and that's what we call the interictal phase. And I was first introduced to this when I took, I'm sure many of you know of one of probably the most famous neurologists in the world, Oliver Sacks, who's a popular author. And he's a neurologist in New York City, and I took him on rounds one day at the Mayo Clinic. And he wears sunglasses all the time and wears a cap. And he said to me one day, we're riding the bus down to the hospital, he said, "I bet you wonder why I have these sunglasses and the cap on." I wasn't really wondering that, but I said, "Why?" And he has migraine. He's constantly sensitive to light. So the interictally, or between attacks, we used to think of migraine as just a paroxysmal disorder, where people are normal in between their attacks, and then they have an attack where they're not well for a period of hours to days, and then they're normal in between. But a lot of people that I see, and a lot of people out there with migraine, and I'm sure some of you in the audience who have migraine will agree with me, that even in between attacks you don't feel quite right, even if you're not having headache. So there's this interictal period where the brain is still not functioning properly. And so that's given rise to what we think of now as migraine being an altered state of the brain, not just during attacks or full-blown attacks, but even in between attacks. And we have networks in the brain, so if I shined a light in your eye, a certain network would light up. or if with the sound of my voice, certain networks are lighting up in your brain. And when we look at the networks that are active just at rest in a migraine sufferer, particularly one who has frequent migraine, we see that these networks are hyperactive. They're processing sound and light when there is no sound or light. And when there is light, even low-level light, it's almost like the gain or the volume has been turned up. So that's why when I'm in the car with my wife and I want to listen to the music a little loud, she has migraine, she can't stand, even if she's not having a migraine attack, she can't stand when the music is loud because of this processing of this information. So you can see here the auditory network and the visual network constantly processing information, the affective network, or the network that controls mood, anxiety, emotion, and then of course the sensory network, the network that processes pain. So migraine is an altered brain state where people are sort of just at the surface. And so it's no wonder why they seem so susceptible to triggers. And there are a lot of triggers for a migraine attack. And here are some of them: stress, hunger, if you miss a meal, if you don't sleep well, if you sleep too much, dehydration, certain things in your diet, alcohol, caffeine, environmental stimuli. I seldom see a patient who doesn't tell me that they can predict the weather. So these changes in barometric pressure will trigger an attack. And then changes in estrogen level in women. 3/4 of women who have migraine will develop changes in their migraine attacks during pregnancy, during menstruation. So these fluctuations in estrogen is a very potent trigger for migraine. So life is a trigger for these patients. Sometimes patients will just wake up spontaneously. In fact, about half of migraineurs, they'll wake up with an attack. So what were they doing when they were sleeping? So even sleep itself, as restorative as it is for some patients, can actually trigger attacks. So that's what, and so these patients are sort of skating under the surface, if you will, and it doesn't take very much to trigger a full-blown attack of migraine. And as Dr. Parekh said, chronic pain hurts the brain. Chronic pain changes the brain, and those changes then sustain the pain. So that if you do imaging in a patient with chronic pain, it doesn't quite look like the normal brain. And this is an example of that. And you know, you don't need to know what I'm showing you, but Dr. Parekh has already told you that the brain of a patient with chronic pain changes functionally. It's very responsive to the environment. So if this light is not uncomfortable to me, but for a migraineur, it would be uncomfortable. And for a frequent migraineur, or those who experience frequent attacks, it's extraordinarily uncomfortable. So the function of the brain changes and the structure of the brain changes. Areas of the brain that process pain actually grow in size, and areas of the brain that are probably responsible for controlling pain, because we have areas in our brain that control pain, actually seem to shrink. So pain changes the brain both functionally and structurally. Which brings me to my last couple of slides. In the last 50 years, actually in the last 7,000 years, we've had one drug class that's been actually synthesized, designed specifically for migraine, and approved by the FDA for migraine. One. That's dismal. For a disorder that's the third most common disorder on the planet and the fourth most disabling among women, there's something wrong there. What's wrong is that for every $100 spent on research in the United States, 5 cents is spent on migraine. That's about 1/20th of 1% of the federal research budget. So it's very difficult for very bright minds in this country who want to work on this problem to get the funding to do the kind of research to advance this field forward. I don't want to leave you with all bad news. The good news is that, and probably this is probably the best news for me in the last 24 years interested in this field, is that we're finally starting to understand the biology of this black box that we used to call migraine well enough that we can now design drugs specific for this disease. What a great day it will be when a migraine patient walks into my office and I say, you have migraine, and now I'm going to give you a treatment that was designed to treat migraine. Because now, if I want to prevent migraine in a patient, I have to give them a drug that was designed to treat depression, or epilepsy, or high blood pressure, or wrinkles, but I can't give them a drug that was actually designed to treat migraine. But now we're here. We actually know enough about the disorder now that we can actually target a very specific protein that we think is critically and crucially involved in developing a migraine attack. And so now we've got these monoclonal antibodies. Antibodies, of course, we produce in our own body to fight off germs, bacteria and viruses. Well, we can synthesize and engineer antibodies that are directed towards anything. And so this protein called CGRP that seems to be very important in migraine, now monoclonal antibodies have been harvested and synthesized to go after that protein. And some of the early results from some of these phase 2 clinical trials appear to be very promising. So we've come a long way in 7,000 years where we're using hand-me-down drugs to treat a disease. We now know enough about the biology of the disease to be designing drugs specific for that disease. But we've got a long way to go, obviously. And so rather than continuing to fight for dollars that aren't there, I decided to start, because I chair the American Migraine Foundation, I decided to take the fight to the people who care the most, and those are patients who suffer with the disease. So we started, through the American Migraine Foundation, the 36 Million Migraine campaign, because there are 36 million migraineurs in the country. So our goal is to raise $1 for every migraine sufferer in the United States. So if we raise $1 for every sufferer in the United States, we will almost double the annual research budget that's dedicated towards migraine. So a little can make a whole lot of difference. We have the Brain Trust in the United States and abroad to be able to collaborate and to work on this and to advance this in a very meaningful and rapid way. We simply need the funding to do that. So those are my comments, and I think we have a question and answer panel. So thank you very much for your attention.
We'll be running the mics for anyone who has questions. Just raise your hand and we'll bring the microphone to you.
Thank you. My name's Nita, and ever since I was knee-high to a grasshopper, I always suffered with the migraines and stuff. In the recent years of maybe from the last 5 to 10, has there been any new migraine medications come out that we don't know about? We know about the triptines, but has there been anything new that's worked well?
Unfortunately, no. You mentioned the triptans, and that was the one class of drug that I mentioned that was specifically designed and approved to treat migraine. The triptan drugs treat the acute migraine, right? The full-blown attacks. They don't prevent migraine. Unfortunately, about 1/5, 20% of patients with migraine can't take them because they constrict blood vessels. And so if they have heart disease or high blood pressure or any other vascular disorder, they can't take them. And only about 30% really respond well. And by responding well, I mean they're pain-free in 2 hours and they remain that way for the rest of the day. So unfortunately, no. Now, there are some drugs that the most recent drug to have been approved for migraine or migraine prevention was botulinum toxin, or Botox. Now, obviously, Botox was never designed to treat migraine, and it was discovered by serendipity to help some patients. But that's the most recent drug to have been approved for migraine treatment. There are some devices that have been approved, so devices that stimulate the scalp. So one device was called the Cefaly device, C-E-F-A-L-Y. And really, it's a device that almost looks like a tiara that the patient puts over the eyebrows. And it just provides transcutaneous electrical nerve stimulation of the nerves that come out around the eye. So it's basically TENS for the nerves that come out above the eye. And then there's one other device that was just approved, but it's not commercially available, called a transcranial magnetic stimulation device that patients actually hold over the back of their head, and it provides a magnetic pulse. But there have been no medications that have recently been approved other than Botox, and that was back in 2010, I believe, Botox was first approved. So hopefully we're encouraged, we're optimistic with the results of these monoclonal antibody trials, and those are the most promising drugs in the pipeline for migraine right now.
First of all, let me congratulate you on a fine set of talks. Very, very interesting, very enjoyable. There are some interesting new mathematical models of the mind. If you're curious, I'll talk to you after.
Okay, will do. Thank you.
I didn't quite understand the last slide about the peptides and some type of protein research. If you could expand on that.
Yeah, so we've known for probably 30 years now that there's a protein. It's actually a neuropeptide. It's a neurotransmitter called calcitonin gene-related peptide, or CGRP. It's very abundant in the brain. It's abundant in most tissues in the body. But it seems to be released during a migraine attack. And when migraine attacks are relieved, if you're measuring that peptide in the blood, commensurate or coincidental with the relief of pain, that peptide goes back down to normal levels. In the nerve that we've been focused on in the migraine field for 20 years now, this trigeminal nerve, which basically innervates or supplies pain fibers to most everything inside of the head that's pain sensitive. This peptide is very prevalent, and that's where we think it's released. So this peptide allows the peripheral nerves that supply all the pain-sensitive structures inside the head, it allows that peripheral nerve to communicate with the nerves inside the brain. So we felt that if we blocked that peptide or that protein, we would probably have a medication that would work for migraine. And indeed, now we have 5 CGRP receptor blockers. So CGRP is a protein, it's like a key, and a receptor is like a lock. And so we have basically designed 5 drugs that basically attach themselves to the lock and prevented the peptide from binding to its receptor to exert its effect. All 5 of them were effective. Unfortunately, a couple of them had some liver toxicity, and so liver side effects. So they've been slow to be developed. There are a couple that don't appear to have liver toxicity that may be developed, but that was just another piece of evidence that this protein or this peptide is very important for migraine. And that led then to the development of these antibodies. So if the antibody binds to the protein and doesn't allow it to exert its effect, do its thing, if you will, inside the brain to generate a migraine attack, then presumably we could prevent migraine attacks with these drugs. And as I said, preliminarily, the early phase 2 studies appear to be positive. So you're going to be hearing a lot more about these in the future. What's nice about these compounds is that they're very specific. They bind only to that protein. So there's no what we call off-target toxicity. It doesn't affect other tissues, other organs, other proteins. So it's very specific. And so far it seems to be pretty well tolerated. So we're optimistic about that.
One of the problems we have in the antibiotic world is that there's a great increase in drug-resistant organisms, and there's need for new antibiotics. However, because it costs so much money for a pharmaceutical company to make a drug that is acceptable to the FDA, that I don't know if the same parallel thing happens, because we are not getting new antibiotics because the pharmaceutical companies just cannot afford the millions of dollars that it takes to get FDA approval. So I don't know if there's a parallel there here or not.
Well, we've had a couple of fascinating talks during our symposium. Maybe I'll let Dr. Parekh speak to that.
Great. Yeah, thanks for your question. Yeah, you're absolutely right that developing a drug just is extraordinarily expensive. And one of the points that I made in my comments is that we don't have a lot of new drugs that are useful for the treatment or coming out that are becoming available for the treatment of chronic pain. So as Dr. Dodig pointed out, the outlook looks much brighter for migraine because we do have this new insight into a mechanism that is very, very critical and central to the development of migraine. But in saying that we don't have a lot of new medicines, what you should realize is that it's not for lack of trying. And the pharmaceutical industry has spent billions of dollars in trying to develop new drugs for the treatment of pain. And as Dr. Dickstein pointed out in his comments, pain is very, very complex because it has these sensory features. You know, you think about pain as being something that is associated with a part of the body, but then it also has these other qualities, these emotional qualities that are very, very hard to understand and very hard to modify. And so that's been a real challenge for the pharmaceutical industry and for people that are engaged in pain research to find those mechanisms that actually could change what the real human experience of pain is. So it's extraordinarily expensive. I think the downside of the failure is that many pharmaceutical companies have de-emphasized their interest in developing new pain medicines in spite of the medical need that I showed you. And so, but hopefully we will have some breakthrough medicines in the future that will re-energize the drug discovery process.
Just to add to that, I completely agree with what Dr. Preka said and with your comment. I think the drug development in this country is unsustainable at its current pace. It takes about $2 billion to get one drug to market. 99% of drugs fail either in phase 1, phase 2, or phase 3. We recently had an example in the migraine space where a drug came all the way through to late phase 3. Well over $500 million was spent on the development of that drug, and the drug, crashed at the end of phase 3. So it's extraordinarily expensive and unsustainable, really.
What makes it so expensive? You're talking about $2 billion to get one drug to market. What makes it so expensive? Is it government regulations? Is it just too much? Is it the amount of research that has to be done? Is it the amount of trials that have to be done because of government regulation?
Well, it's not all because of government regulations. I mean, there is a very well prescribed and defined process by which new drugs are introduced into clinical practice. So the first thing that has to be done is research at the basic level to actually find the molecule. And so finding the molecule is complicated, and it takes years and years, and that costs a lot of money. But the place where it really starts to cost money is when the molecule is actually introduced into humans in the clinical trials, in the clinical development of the drug. And I think the statistic that may help you make sense of this is that if you were to bring 10 molecules into the crucial clinical trial where you test to see if the drug really works, because the initial clinical trials are whether the drug is safe and tolerable, et cetera. But when you get to the point where you really want to know if the molecule that you've made is going to be effective in humans, 9 out of 10 of those will fail there. And so all that investment up to that time point is lost. But even that is actually better than failing later, because as it goes into the more advanced trials, where the trials are done in multiple places around the country and around the world, with many, many patients, hundreds or thousands of patients, that's where the real expenses come. And many of these steps, showing that the drug is safe, showing that the drug works, showing that the drug works in many, many different types of patients or populations, these are all mandated and reviewed by the Food and Drug Administration. And so in order for a drug company to get approval of their molecule, they have to go through all of these processes. And all of these, just mount cost with time, and it takes more than a decade, 12 years or more, to go from the earliest stages of research to the later phases of clinical trials. So that's a long, long period of time and a lot of money, and that I hope can put in perspective.
Thanks for your brief lectures. Very interesting. You mentioned the stigmatizing feature of migraine and by extension, chronic pain. People who come into the emergency room, for example, are frequently identified as drug seekers because there is often no objective finding, as you pointed out. Ross, I'd be interested in your thoughts about how you deal with people who have these serious pain problems without any objective evidence to demonstrate the severity or even the existence of physical pain. Maybe it's all just emotional drug seeking, but how do you as a doctor actually grapple with this problem?
It's a great question, Don. You have to assume that a person comes into the emergency room is telling the truth because there is, at present, very little way to objectively measure chronic pain. Even acute pain, the usual symptoms that we see with acute pain, rapid heartbeat, dilated pupils, rapid breathing, sweating, are absent in chronic pain. So I think our first duty is to assume the person is telling the truth. That being said, there are drug abusers, there's people looking to get high, looking to game the system. Nonetheless, I think we're doing better identifying these people that are truly in need. And there's a syndrome beside dependence or addiction. There's something called pseudo-addiction, where patients in pain are undertreated, and they're just looking for enough medication to get them feeling well enough to go about their business again. So pseudo-addiction is different than addiction or abuse. The people are truly undertreated. And as government regulation makes it tougher to prescribe for these 130 million people that Dr. Pareca talked about that have chronic pain, and insurance companies put caps on the amount of pain pills you have. When a person with cancer can't get more than 60 pain pills a month, well, they're going to run short and they're going to be in pain. So it's a terrible dilemma, and the ER is the front line of this, where these patients come in waves, and you've got to rapidly distinguish: are they drug seekers, or are they truly in pain, and are you missing something that some medical illness that needs to be treated properly? So it's a very tough conundrum.
I'm at a tertiary or quaternary referral center, so I get referred patients from around the country who have failed everything. I rarely see addiction, rarely. And so that's part of that stigma that really has to be dissociated from the overwhelming majority of patients who come in seeking pain relief. And unfortunately, that dogma and that stigma sort of colors the 98, 99% of patients who are simply looking for pain relief. That's one thing I'll say. The second thing is we just finished a big systematic review on what patients across the United States and Canada are actually getting in emergency departments. And unfortunately, when a patient first comes into an emergency department with a migraine attack that isn't adequately being treated at home, what do they get? An opioid, right? They get an opioid. They didn't ask for the opioid. That's just what was given to them. So the next time they come into the emergency department with an untreated attack, guess what? Oh, Mrs. Jones was here just 3 weeks ago and she got Demerol or Dilaudid, right? She got her opioid. So now she's here for more. And that's the vicious cycle. That's the way these things happen. There are at least a dozen medications, non-opioids, that can be delivered very effectively in the emergency department and are very effective in treating migraine, much more effective than opioid. So we have a plethora of options to be able to treat migraine patients in the emergency room without giving them an opioid. In fact, there's evidence now that giving them an opioid will only perhaps perpetuate their pain over time. So it's unfortunate what's happening, and many of the trainees that I get, they come and spend time with me, probably because they feel like they have to, because I'm their program director, and they don't really want to spend time with me or do headache, but when they get in there, they can't believe the patient population. They are so grateful, they are so appreciative of just having someone listen, show some compassion, and offer some suggestions and some hope. Because they came in with this preconceived notion that they're going to be dealing with these drug seekers, so to speak, and it's a terrible stigma.
I'll just add one further comment to that. And you were bringing up the issue of how you actually know that the patient has pain, and Dr. Dickstein made the point that you have to believe them. And that's because pain is not something that we can measure. We don't have a blood test for pain. So pain is different from other conditions where you can actually have something that you can measure and verify that this is actually the case. So pain is something that really is individual in that patient. And so I think it's really imperative that individual be believed about their pain. And so as Dr. Dodig pointed out, the appropriate treatment then would have to be decided on at that point.
Maybe just one more comment, and that is that as Dr. Perkins said, pain is such a subjective and personal experience, and everybody expresses that in a different way. Some people have what physicians like to call pain behavior, right? They're showing you, they're trying to demonstrate for you how much pain they're actually in. And by and large, healthcare providers don't like to see that. On the opposite end of that is the patient who comes in very stoic, who may be in a tremendous amount of pain, and the healthcare provider will look and say, they don't look like they're in much pain to me. So these patients can't win. They come in, they don't know how to behave, but they have to express to you somehow, some way that they're in a lot of pain and they need help.
So I deal with a lot of workman's comp injuries, and it's amazing how the employer can either add to the pain that the patient has or help relieve it by the attitude they have. And I think a lot of the emotional issues involved are not being treated well at all. And having worked in the emergency room, it's not the place where you get counseling, and a lot of people do not have the time to listen and to be sympathetic. So it's all up here. And I think it's exaggerated by a lot of other emotional things that are happening. But what I don't see is research into why does everyone need a pill? If half of the pain is emotionally based, I think you have to hit it in both places. So could you just talk a little bit about research in emotional side of pain?
Yeah, I can make a couple of comments. I mean, I think that there are a lot of other behavioral treatment approaches that are being implemented and that are recommended as well. There are acupuncture kinds of strategies that are employed. There are stimulating devices that Dr. Dodig mentioned. So there are non-pharmaceutical approaches that are useful and are useful in some, but perhaps not all, patients.
Yeah, I would say I completely agree with your comment. I mean, when patients, and I agree that an emergency department is not the place to provide overall comprehensive care for that patient. It is the place to ensure that, the patient's treated with respect and compassion and that their pain is relieved to the best of that provider's ability. It's also incumbent then to get that patient to a provider who then has the time to sit down. When patients come to my clinic, I have a nutritionist, I have an exercise physiologist, I have 2 psychologists who do what we call cognitive behavioral therapy, biofeedback, relaxation therapy. We have 2 acupuncturists. We have a pain clinic, which can be helpful at times with our anesthesiologists. So we have physical therapists, right? So we have a multidisciplinary, multimodal approach to what is a very complex problem. We also have psychiatrists who deal specifically with chronic pain as well. So I need to be surrounded by a lot of friends and a lot of expertise to manage the very complex beast that is chronic migraine. There's a scientist here who gave just a superb talk today who could speak to this much better than any one of us, and she actually gave a presentation today on this very issue and how some patients really probably will respond even better to cognitive behavioral therapy and some of these other therapeutic approaches than medicine, actually.
And let's not forget about the subtle or not so subtle rewards of having pain. People get increased attention from spouses and families. They get time off of work. They get money from workers' comp and other people. So there's some subtle rewards for having pain, and this is where the system breaks down. You want to treat the pain in the way these gentlemen have described, but you also want to, you don't want to reward pain behavior.
I have a question, and I'm not exactly sure who to direct it to. Something I've noticed recently in various emergency departments and stuff, they've come up with new protocols on how to treat someone that comes in with a migraine headache. And, you know, yes, they're saying no opioids and stuff like that, but yet what they're trying to treat you with ends up affecting you, we'll say 4 to 6 hours later, in an adverse way. Have you noticed that emergency departments are trying to get away from the opioid for the person that does suffer the migraines to go to this new protocol instead of when the person tells you, I've got a migraine, I've been throwing up all day, you know, I'm doing really bad, but yet they say, okay, let's try, quote, Benadryl, and it nails you later, and that for dry throat and coughing and stuff like that. Do you understand what I'm trying to say?
I understand exactly what you're trying to say. And in our emergency department, for example, at Mayo Clinic, none of our emergency doctors give opioids. I have established for them a number of different protocols, and depending on the patient, they tailor the protocol for the individual patient. And sometimes they may not get it right the first time, and so they can mix and match. But as I said, there are many medications beyond Benadryl, of course, which we don't use very often, but there are many medications that will rescue a patient and provide relief that will be sustained. So opioids are really not used in our emergency department, and nor do I think they should be, because they've never actually been shown to be very effective for treating migraine. We have more effective therapies, and as I said, they can help to perpetuate the problem over time. So.
Hi. You said that there were 5 other new medicines besides opiates, or in my case, epidurals. I've tried everything. These 5 new medicines you talked about that aren't opiates, do they apply to chronic pain as well as migraines?
Yeah, so there were 5 new medicines that have been tested for migraine, and all were found to be positive. But unfortunately, a few of them, as I mentioned, had some liver side effects. So they're no longer being developed. But there are a couple of others that may be developed in the future.
They're not available now?
But they're not available now. And, you know, to develop these drugs further will take 2 very large and very expensive trials that will take a couple of years to complete. So that's why it takes a lot of time and a lot of money. Even these drugs that I showed you here, these antibodies, we've got a long way to go, and it's probably not going to be for another 3.5, 4 years if everything goes smoothly before we see these drugs commercially available. So it takes, as Dr. Parekh said, it takes 10, 12 years, a decade to get a drug from the time you synthesize it all the way through to where you can actually get it approved. So there are new drugs in the pipeline, and we're very optimistic, but we're several years away from getting approval for any one of them.
Hi, I'm a veterinarian, and we don't really recognize headache in dogs and cats, but I'm wondering if research is done using animal models and or if there's a way to induce headaches in animals or humans as part of the research.
I'm sorry, your question is, can you induce headache in an animal? Well, there's no reason why animals can't have headaches. So if you look at the anatomy of the trigeminal system that Dr. Dodick spoke about. It's very, very analogous to what we see in humans. And so there are examples that have been reported in the veterinary literature that show that companion animals like dogs, for example, will show signs that are very similar to human migraine. And so they'll show features that can be interpreted as the animal experiencing a headache. And the animals can actually be treated with many of the same medications that are used in humans and can actually produce benefit in those individual animals. So I think we will never know for sure because we really can't tell what kind of pain experience an animal would have, but I think we could infer that an animal could have a headache and possibly a migraine that would be very much analogous to what a human might experience.
I don't watch all that much football anymore, but what I do watch is a tremendous increase in the impact intensity. And now there has evolved what they're calling the chronic traumatic brain syndrome. So I don't know how that plays into this overall picture.
Well, yeah, you're right. I mean, concussion is the topic of the day, isn't it? Particularly in sport in this country. And I see a lot of amateur and professional athletes who have symptoms that persist after repeated concussive brain injuries, including chronic traumatic encephalopathy, which is this punch-drunk encephalopathy syndrome that was originally described in boxers. But the most common symptom of concussion, of course, is headache, which in the overwhelming majority looks exactly like migraine. And in about 30% of them, it persists. So I have many professional athletes, professional hockey players and professional football players, who can no longer play the game and had to retire because getting their heart rate up to any degree at all will cause a headache like their head's going to explode. So post-traumatic headache after a concussion, as well as other serious symptoms that they have as well, like the cognitive and the emotional, irritability and the mood changes that they have, can really disable some of these athletes. So we don't yet understand the mechanism of why pain occurs after a concussion, nor why it's sustained. A lot of research needs to go into that yet. And because the mechanism is probably different, even though it looks like migraine, it doesn't behave like migraine. So the drugs we typically use to treat migraine, they don't work in that population by and large. So we've got a lot of work to try to better understand what actually happens in the brain during a concussion. And we as yet haven't had a single trial to use a medicine or to use anything that at the time of injury that will mitigate or minimize the brain injury that occurs over time. So we've got a long way to go in concussion.
Hi, I had one question, which is kind of just a curious question to me. The original, back in the 40s, concoction of LSD was originally conceived by a guy that was looking at migraines. Were any of the dilethamides ever shown any promise? Did they ever come to anything? I don't know of any of that. Do you?
Well, a closely related derivative is the ergotamine derivatives are closely related. And ergotamine has been used for a very long time in migraine, for over 60 years. In fact, we're still using it today. They don't have the hallucinogenic properties, but they can be very effective. In fact, dihydroergotamine, one of the ergotamine derivatives, is one of the more effective medications when it's delivered intravenously for migraine. And so hopefully soon we'll see there's a nasal spray available with that medication. The oral tablets are not very bioavailable. They don't get absorbed well, so they're not very effective. But soon hopefully we'll have a puffer that'll be almost like delivering it intravenously. So hopefully that will be approved, and that's very close actually. So that'll be it's an old drug with a new trick now. So yeah, and in response to your question, some closely related derivatives of those drugs are used and are effective.
Would one of you be able to give any advice on if you're seeking out a nutritionist? What are you looking for, and what would a potential workup or program look like? There's a lot of crazy things out there, so I tend to pull back and sometimes cancel it all out, but I think it's a very important aspect in treating migraines in particular, and so I wondered if you had any advice on how to look at a nutritionist, or what do you look for?
Yeah, well, you know, most patients by the time they get to me have identified any of the dietary triggers that might be responsible for some of their attacks. So, you know, very popular ones to eliminate are chocolate and caffeine and alcohol. And no question, alcohol can certainly do it, and caffeine withdrawal can certainly be a trigger. Not so much caffeine itself, but it's the withdrawal from caffeine. But, you know, I have a lot of patients who come into me anecdotally and say, you know, I'm so much better after I went on this gluten-free diet, or the South Beach diet was the answer. And so we really don't understand yet, and we don't really have the testing available to determine which foods are actually triggering an individual's attack. So I'll give you, there was a study published about 2 years ago that tested a group of patients with migraine to 242 different foods, and they looked for antibodies to those foods. And they gave patients who had antibodies, high levels of antibodies to certain foods, a diet that was rich in those foods. And lo and behold, they got more frequent attacks. And then they gave that same group a diet that was depleted in those foods, to which they had antibodies, and their migraines improved. So I think for many years, even I have sort of diminished the influence of diet on migraine. And probably I shouldn't have done that, because it probably plays a prominent role in some patients. But by and large, I think by the time they get to me, they've identified the triggers that are present in their diet. The problem, like so many things, I said, you know, life is a trigger for migraine. And as I tell patients, you know, diet triggers are like matches in a box. If you go on these elimination diets, it's like taking out a match. One match, there's so many more matches with which to light the fire, so to speak. And so it's identifying that big match for that patient. And by and large, diet doesn't represent the big match for most patients. Yes, some manipulations like avoiding alcohol and things like that can minimize the number of attacks, but it's not really the big match for the overwhelming majority of patients. But for me, the nutritionist really sits down and reviews their diet and tries to eliminate at least those dietary ingredients that have been associated, like monosodium glutamate and processed meats and nitrates and things like that, that have been associated with migraine.
I've been very, very lucky that I've never had migraines. And I feel for the people that do, but I do have back pain. The only treatments that I have found for the back pain are either an opioid or injections. And my question is I have sort of stayed away from the opioids. I have them, I take them occasionally, but you get so much press anymore about, hey, you're going to get addicted to those, blah, 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 that type of thing. Okay, that's that's one question. My other question, at Mayo, you have this team of experts that really treat the whole patient. And how do you do that with the amount of cost for the normal person?
I'll let Dr. Preka take the first question.
So the question of addiction and pain. I think that patients that are treated effectively with opioids, for the most part, don't go on to have addiction. So I think that is a risk. It is a risk perhaps in some individuals. One part of the problem is that it's a little bit hard to predict if an individual might have an increased risk, although there are some things that can be evaluated. But I think there are many examples of patients that are treated very, very effectively with opiates for long periods of time, and where the opiates can sustain their activity for long periods of time. So the addiction risk is a risk, undoubtedly is a risk, and it's a higher risk in some populations, but for the most part, they can be very, very effective. I don't know if Ross wants to make a comment on that.
In terms of back pain, as Dr. Pareka said, opioids can be an effective tool. We try not to do too many steroid injections. I think you alluded to that. They are helpful for flare-ups of nerve-related back pain, not quite so good for the ordinary garden variety back pain per se. There's lots of other therapies and different classes of medications, exercises, surgery when indicated, and we're probably seeing less indication for surgery these days. The new focus now is on biological rebuilding of discs, and we hope that that'll be realized in the next 10 years or so. And then as far as the Mayo Clinic, I'm going to send that back.
Yeah, you know, when I said I'm surrounded by a multidisciplinary team of experts, not every patient needs every one of those people. So you may come and you may only need to see me, although that's not typical. But I may only need to draw upon one or two of my friends to be able to help you. So it's seldom that a patient has to avail themselves of all of those experts. And so we try to tailor the approach to the individual patient. And so we try to do that by minimizing cost, believe it or not.
Okay, we have just a few more questions, and it's right around 9 o'clock, so I'll take the last ones.
Thanks for coming out tonight. My pain management doctor has mentioned some things about some stem cell research. I just wondered if you could touch on that at all, if you were aware, for migraines.
Stem cell research for migraine. No, I'm not aware of any stem cell research going on right now for migraine. I know there's research going on in the concussion space with stem cells, but I'm not aware of stem cell research for migraine.
You talk about brain imaging. My mom suffers from horrific chronic pain, found very few people that know how to even talk to her about it, how to help her with it. And I was just wondering if in that analysis of what that pain is, I mean, MRIs, et cetera, are always suggested, but I've never heard of anybody suggesting brain imaging. Would that be something that would be beneficial for her to understand the impacts on her brain and the whole neurological process to be able to identify a beneficial drug? Because the challenge that he talked about is, you know, you need to take 8 a day, and her insurance will only give her 90 pills, and so every 10 days she's going back to try and get what's appropriate for that pain medication or that treatment. But I was just curious if I've never had anybody offer brain imaging as an option to diagnose her.
So, many of our comments as it related to brain imaging is more as an investigational tool. So a lot of the imaging we showed is functional brain imaging, where we're looking either at brain structure or brain function and the influence of pain on the brain, so that we can see what areas of the brain are involved in processing that pain and where the changes, what areas in the brain are actually changing in response to the pain. Conventional imaging, like a routine CAT scan of the brain or a routine MRI scan of the brain, will be unrevealing in the overwhelming majority of patients with migraine or any chronic pain syndrome. So I wouldn't recommend imaging just for the sake of imaging, because it's not really helpful diagnostically and it's not helpful therapeutically. It won't guide clinical decision making as to how I'm going to treat you as an individual patient. And so I don't want you to take away that sort of message, because we probably do, well, not probably do, we do far too much imaging in this country. We spend $100 billion a year in diagnostic medical imaging in the United States, which is a gross amount of money, actually. And so many of the patients I see come with 4, 5, 6 MRI scans of their brain. They get annual MRI scans, and of course, nothing changes. But it's hard for a patient to believe that they could possibly have this much pain in their head without something showing up. And of course, it's a problem with brain function. It's usually not a problem with brain structure, or there's no structural abnormality in the brain that's causing the pain. The other problem, of course, is that physicians, because of our medical legal system, are very concerned that they're going to miss that one patient in 10,000 that has a tumor or some other lesion that could be causing the headache. So even though the patient has had these headaches and they're long-standing and they have a normal neurological examination and there's no reason to suspect a tumor or anything like that, they get a brain imaging study anyway. And if they go to another doctor, that doctor wants to do another imaging study. So we do too much diagnostic imaging. But I'm getting away from your question, which is, should your mother have a brain imaging study for the chronic pain that she suffers from, and would it help guide the physician in terms of helping him make a decision as to how to treat? I think the answer would be no.
Besides the physical pain we go through with chronic pain, we have to balance how we represent ourselves to other people if we do have to resort to an epidural or opiates. We are really people who are a bit in hiding because people look at you and they think, you're taking a drug for something like that? And you really can't share it with anyone. And then when you go into a doctor, you're hoping that he will relate to you in a direct way. It's so hard to get information. Even moving up here, I used to live in California. I went to 7 surgeons. Just my dad and I thought, let's go for it. And none of them would do surgery, and so they offered opiates again. What about those people who take it responsibly and are not going after drugs? We are so looked down upon by the average person for trying to take the pain away.
Well, that's profound. It is. It goes back to the lack of training, the lack of education in undergraduate and postgraduate medical training. And that's one of the reasons for this national pain strategy, is to educate the public as well as all healthcare providers, have a better understanding of the biology of chronic pain, why patients complain, and why patients report the symptoms that they do, and how best to treat it. As Dr. Parekh said, many physicians now, because of the scrutiny that both state and federal regulators impose upon them when they write a prescription for an opioid, are skittish to write an opioid, even when it's indicated. Because as Dr. Parekh said, if we had better drugs that were not addictive and were not as scrutinized as the opioids, we'd be using them. We'd be using them. But right now, again, as Dr. Parekh said, over the last 25 years, every pain medication that's become available is a derivative of an opioid or an aspirin. So we have very little choice right now. But when a patient and a physician have an established relationship and they know one another well, and there's it's a relationship of trust, then I think opioids can be used responsibly. That would be my answer to you. I think opioids can be used responsibly. But because of both the policies that have been put in place to regulate opioids, physicians are, rightly so, skittish about them. I think systemic issues with opioids? Well, it's more the scrutiny that they're going to come under for prescribing them. And also the fear that patients will become habituated and addicted. And also these accidental overdoses that Dr. Parekh talked about. There's also with chronic pain come mood, anxiety disorders, and sometimes there's co-prescription of other medications that when combined with opioids can be quite harmful. And so again, it comes down to you and your physician. If you have an established relationship and it's built on trust and your physician knows you, then I think if everything else has been exploited and looked at, all other options have been looked at, for some patients, opioids can be used responsibly and have been used responsibly and are used responsibly by physicians all over this country every day.
Yeah, I'll just add one other point, and that is beyond the risk of addiction is the concern of diversion. So if you look at the areas of the country that have the greatest risk of abuse of opioids, of prescription opioids, you often find that these are associated with areas that have economic stress. And so I think that one of the things that occurs is that concerns about diversion often relate to other societal issues such as poverty. And so in many, many cases, you know, there are patients that need the opioids, that are given the opioids appropriately, but you know, can need the money. And so there are issues like that that make this this question of opioid use even more complex. But as Dr. Dodig pointed out, there are very, very appropriate ways of monitoring appropriate use of opioids in individual patients, and a relationship of trust between the doctor and the patient, monitoring the use of opioids, monitoring the levels of opioids that are in the individual patient can really help with maintaining responsible use of those medications.
Well, I think without even addressing the issue of cannabinoids in Colorado, we'll close this panel. I'd like to thank Drs. Parekh, Dodig, and Russ Dickstein for coming to this very successful event. Thank you.
I'm amazed by that. Thanks very much. Thanks, David. Thank you. It was fantastic. You were superb.